Dr. Rovin, my rheumatologist has told me that I have protein in my urine and that I might need a kidney biopsy. What does that mean?
So, Ms. Moss, what do you see your rheumatologist for? Could it be lupus?
Yes, it is.
I see. So how long have you had lupus?
For a long time now.
Okay. So sometimes lupus does involve the kidney. As you know, it involves a lot of other organs. Maybe it's involved your joints and your skin, that sort of thing. When it involves the kidney, we often see protein in the urine. That's one of the important characteristics. And we tend to do a kidney biopsy in those patients because we need to understand what's actually happening in the kidney so we can treat the patient correctly.
Okay. Is it painful? Does it take a long time?
So kidney biopsies have really come a long way. Nowadays we do them as an outpatient procedure. It really isn't painful. We numb up, we approach the kidney from your back. Okay, so you'll be lying on your tummy with a pillow underneath, and then we visualize the kidney using an ultrasound machine, which is nothing more than sound waves and a microphone. That doesn't hurt at all. We then numb up the whole area all the way down to the kidney. And we take a fairly small needle and put it in. It's called a biopsy gun, not that we're going to shoot you. And it's a spring-loaded biopsy needle. And then we just take 2 cores of your kidney tissue for examination under the microscope.
And how is this going to be treated? I mean, how did I get this?
Well, how you got it is sort of an interesting question. It turns out about 50% of patients with lupus will eventually have kidney disease. Okay, and we're not entirely sure what predisposes some patients to have the kidney disease and other lupus patients not to. And that's something that a lot of active research is being conducted to try and figure that out. But in terms of how to treat it, there's a whole variety of medications that are available now to treat the kidney. And of course, a lot of that really depends on what the biopsy shows.
Oh, okay.
For the kidney pathologist who looks at the tissue, there's a very complex sort of designation of what we might see. But just so you understand, the main things we're looking at are whether there's a lot of inflammation. So in other words, your own white blood cells have entered the kidney and they're sort of attacking the kidney. Okay, and these very inflammatory types of involvement in lupus we call class 3 or class 4. That doesn't matter much to you, but to me, class 3 or 4 are the types of kidney disease in lupus where I want to be very aggressive in treatment. I want to make the immune system very quiet so that these cells stop harming the kidney. Because what we want is to preserve as much kidney tissue as possible. We don't want to lose kidney tissue. When you lose kidney tissue, the kidney doesn't have a very good ability to regenerate itself. So that sort of becomes a scar and it's lost. So we want to put the inflammation to rest very quickly. The drugs we use for that might be a little bit different and a little bit more aggressive than the types of kidney disease that are less inflammatory. So if it turns out that what you have is maybe called a class 2, we may not have to be very aggressive at all. That really has a very good prognosis. Another one that we call class 5 just really shows a lot of protein in the urine, but not a lot of inflammation. So again, the treatments would be different.
I've had a friend of mine who told me these kidney biopsies are really dangerous and that it could cause a lot of bleeding. And what's going to happen? What are going to be the results, and what are you going to find out on how to treat it?
Yeah, so the kidney biopsy clearly is an invasive procedure. We're doing something, and I have to tell you that it's a relatively safe procedure, certainly in the hands of people who do this a lot, like we do in our biopsy clinic. Bleeding is probably the most common, and almost everybody has a little bit of microscopic blood that you can only see under the microscope in their urine after a kidney biopsy. A small percentage of patients may actually have bleeding that they can see in their urine, and we monitor that. And we also actually check your blood counts after the biopsy a couple of times to make sure that you're not bleeding a lot, before we let you go home. Those complications of bleeding happen in maybe 2 or 3% of the patients. More serious complications where the bleeding doesn't stop on its own happens in a very small percent of patients, and sometimes we actually have to call our radiology colleagues to come in and help us stop the bleeding by putting a plug in the kidney. The worst complication, like any procedure, something could go very wrong and it could result in loss of the kidney or death. I'm happy to tell you that that happens almost never, but I have to warn you about that.
And what is this biopsy going to tell you? Is it going to tell you what I need for treatment?
So that's essentially why we want to do the biopsy. The drugs we use to treat kidney disease with lupus are, and I don't want to scare you, they're called, some people call them chemotherapy drugs. So they are drugs that we've borrowed from the cancer specialty, but they affect the immune system, and that's what we need to sort of make quiet to get your kidney under control and get rid of all the inflammation in the kidney. So these are drugs with important side effects, and before we use them, we really want to know exactly what we're treating. And depending on what we see on the kidney biopsy, we can make pretty good decisions about what to start treatment with.
What did I do? Is there something in my diet? Is there something I did? How did I get that?
Yeah, that's a great question, and a lot of patients ask me that. I wish I could tell you how you got it, but what I can assure you is it was nothing you did wrong, for sure. My guess is that your genetic makeup predisposed you to lupus and then also to lupus kidney disease. And of course, as we talked about before, that's really a topic of research all over the world. In terms of your diet, probably not. Although we do think there are some environmental types of things that might help your immune system kind of tick off into lupus, but we don't know what all of those are. In terms of what you can do to help with this process, we need to make sure your blood pressure is under excellent control, because in any kind of kidney disease, lupus or anything else you think about, diabetes, if the blood pressure is not well controlled, that adds to the injury and it can accelerate the loss of kidney function. So that's one thing we have to monitor very closely. We like to use blood pressure medications that also reduce protein in the urine, because we think that a lot of protein going through the kidney rather than staying in the bloodstream can actually damage the kidney in and of itself. And so there's a certain types of antihypertensive or blood pressure medications that we do like to use. The other thing we like patients to do, and this does involve the diet, is watch their salt intake. If you eat a lot of salt, it tends to cause proteinuria, which means protein in the urine. It tends to cause the protein in the urine to be much, much worse. And it also tends to make your blood pressure very difficult to control. In fact, it tends to really override a lot of the good benefits of our blood pressure medications. So those are going to be things that we're going to discuss in detail. There are some studies that have suggested lowering protein in your diet may be of benefit too. I tend to ask patients not to just get rid of all the protein in their diet, but sort of do things in moderation. Americans tend to have a very high protein diet, and so we might want to scale back that a little bit. And then depending on what your cholesterol is, because sometimes when you lose a lot of protein in your urine, your cholesterol can go up. We may want to treat you with medications that might help bring your cholesterol down. So those are the sort of things that you can do to help yourself.
Great, thank you.
My objective is to get you to go into remission. And so I'm going to tell you how I'm going to do that, or at least some of the options. Let's assume that your kidney shows the inflammatory type of disease. Then we're going to treat you with steroids. Now, you've heard of steroids. The athletes take steroids to enhance their performance. That's not what the kind of steroids we're talking about. We're talking about prednisone, which is a steroid that does have a lot of side effects, but it's very good at making inflammation become quiescent or quiet. Okay? And with the steroids, we're probably going to add another medication, and we're going to work with you to choose what's best for you, and also I'll base it on what I see on the biopsy. But the two medications that are most commonly used at this stage, the very first treatment of the disease, will be something called cyclophosphamide or Cytoxan. And I know people use the internet a lot. You're going to go home and you're going to see that that's used for all kinds of cancers, and it has a huge number of side effects. I want to assure you that we don't use cyclophosphamide in the doses that are used for cancer chemotherapy. We use it in lower doses that are for immunosuppression, so quieting down your immune system. Having said that, there are side effects that I have to warn you about, but they're applicable to all of these medications in general, and then each medication has specific things we need to talk about. The other medication we use pretty often is something called mycophenolate mofetil, or MMF. And that's a drug that we have been using for really a very long time in kidney transplants. And we use that pretty much for the lifetime of the transplant. So we have a lot of good safety data on that drug. And its immunosuppressive effects are a little bit less intense than cyclophosphamide. Now, when we're talking about these drugs, overall, when you're on steroids and any one of these other immunosuppressive drugs, the biggest things I worry about are infection. Okay, because we're putting the immune system, we're trying to control the immune system and suppress it, people are subject to getting infection. And so what I generally tell my patients is, I don't want your life to be impaired, but you need to have very good hand washing. It's best not to put your fingers in your eyes or your nose or your mouth, because that's how colds and viruses can get transmitted. I also like people, especially as the winter months are coming on and people tend to congregate in closed spaces, maybe if you're going to go shopping, do it at an off time when there's not a lot of people around. Try to avoid maybe being with children that are ill or family members that are ill, or just sort of stay away from them. The big thing is, if you feel like you're getting sick in any way, you need to tell us right away. So I'm going to let you have the electronic medical record. You can contact me. You'll have the email and the phone number to the office, because I think that's really important. You have to tell us. If you develop a fever of any type, I have to know about it immediately. Okay. And if you can't get a hold of me, you have to go to the emergency room and say, I am a patient who's getting immunosuppression and I have a fever, because they'll know what to do. So that's with any immunosuppressive drug. We do try to treat you with prophylactic antibiotics to prevent infections, and so we will do that as well. And then some of the specific things with cyclophosphamide, one of the bigger, there's two big side effects that people worry about that you're going to see when you research this on your own, and they're going to scare you. And so I'm just going to warn you that you'll see that cyclophosphamide can cause cancer many years down the road. Okay, but that is based on how much you've received over your lifetime. And so I monitor the amount that you receive if we choose to use that therapy, and we try to keep it under a certain level so that we're not predisposed to getting cancer in the future, okay? And we usually get nowhere near that level. The other big problem with cyclophosphamide is that it can cause a premature ovarian failure, which means infertility. And this is a big issue with people who may want to have children, so you need to think about that. What we tend to do is a regimen of ovarian protection, so it essentially puts the ovaries to sleep, if you will, and protects them. We believe it protects them from that side effect of cyclophosphamide. To tell you the truth, there's been so many advances in the way we use cyclophosphamide. One of the therapies that I really like is called low-dose cyclophosphamide, and that decreases the risk of all the complications considerably. The main complication, other than the predisposition to infection with the mycophenolate, is that it has some gastrointestinal toxicity, and by that I mean people can get diarrhea or nausea or vomiting. So you need to tell me if that happens.
Okay.
But to prevent that, I start the dosing low, and then as you tolerate it, I increase the dose up to the level where I think it's going to be therapeutic for you. And then we do have other formulations of the mycophenolate that have less gastrointestinal toxicity that we can try if necessary.
Okay, great. What happens to this when I start taking the medicine? I mean, will it go away? Will I end up having to go on dialysis? Will I need a transplant?
Okay, we're getting a little ahead of ourselves
Okay.
with the really sort of scary things like dialysis or transplantation. Our goal in treatment with the medications that we're going to talk about that we might consider for you is to put the disease in remission. Okay? Now, whether or not the disease goes away back to totally normal kidneys is something that we're actually studying in my laboratory. I can't answer that now, but I do know that we can get pretty close to normal. And we do have very good recovery of kidney function. In a lot of patients, the protein in the urine goes down to normal levels and their kidney function. So we measure kidney function through a blood test called serum creatinine. And that's a substance that the kidney gets rid of. And of course, if the kidneys aren't working well, it sort of increases in the bloodstream. So that's how we monitor your kidney function. And I'm happy to say that we can get most patients to have some sort of remission with our treatments. Now, we define the remissions differently. Some are called partial remission, so they got partway better, and some are called complete remission or complete responses, and then the clinical findings that your rheumatologist sent you for here have all completely gone away. Depending on the length of time of follow-up and whatnot, but just on average, after about a year of therapy, we'll get between 30% and 40% of patients to go into complete remission, and maybe another 40% of patients to have a partial remission. So 70 to 80% of patients after a year are going to have some sort of good response to the therapy. In terms of dialysis and transplantation, since I'm assuming your kidney function is normal right now, and your doctor has sent me all your laboratories, I need to review them, we have a long way to go before we talk about that. And my goal as your treating kidney doctor is really to prevent that. And we're pretty good at doing that. If it does come down to dialysis or transplantation, and we'll discuss those in greater detail, both are very good options for kidney patients who have kidney disease from lupus. They both work well. There's no downside to having kidney failure from lupus in terms of getting a kidney transplant. And because you're otherwise young and healthy, that would be my option to return you to the most normal life possible.